So today we're going to talk about blood sugar management in cystic fibrosis-related diabetes. In today's talk, I'm hoping that you're going to understand a little bit about how insulin works and the different types of insulins that are available, as well as some of the nuts and bolts of actually administering that insulin to yourself. So to start with, I want to talk a little bit about insulin types. There's several different insulin types, and we talk about this using pretty specific terminology. The first thing that we would say is maybe prandial insulin or mealtime insulin. The other word for this is short-acting insulin. So these are insulins that are going to last in your body for about 4 hours. They're meant to cover just what you're eating or a acutely high blood sugar. So they're supposed to bring down your blood sugar if it's high just right now. It's not meant to last you all day. The second class of insulin is what we call a basal insulin or a long-acting insulin. So some people are on just once daily insulin, and this is usually a basal insulin, and it leaves a small amount of insulin in your body all of the time. So the purpose of this insulin is to basically grab up blood sugar a little bit all day long and maybe to take the edge off of your own body, which might be working reasonably well. If you have fulminant diabetes, like a type 1 diabetic, a type 2 diabetic, or a cystic fibrosis related diabetes patient that has fasting hyperglycemia, you might need basal insulin as part of your regimen to control your blood sugar at baseline and just use it to keep your blood sugar stable when you are fasting. So people who have no pancreatic function, if they don't have a basal insulin, their blood sugar will rise relatively quickly within 2 to 4 hours if they don't have any insulin on board. The basal insulin is meant to keep that blood sugar just very stable. You can also use intermediate insulins. Intermediate insulins last somewhere between 8 and 12 hours, and they're meant to kind of cover you during the daytime or perhaps during a discrete event like a G-tube feed. There are lots of different names of these different types of insulins, and how your physician picks the type of insulin that's right for you depends on your blood sugar trends, your current insulin needs, and how you eat. So if you're eating frequently or snacking, you might have one insulin regimen. If you have G-tube feeds, you might have a completely different insulin regimen. So when we're talking about insulin types, we call these insulin analogs. And I'm just going to run through them relatively quickly. Fast insulin aspart is the fastest insulin analog on the market right now. It lasts for about 4 hours, but it peaks the quickest, so usually about 10 minutes sooner than other short-acting insulins like Novolog or Humalog, which are Lispro and aspart. Intermediate insulins are the ones that are going to last for about 8 to 12 hours. So regular insulin will last you about 8 hours and will peak at about 2 to 4 hours. This is frequently used for G-tube feeds that last 6 to 8 hours. And insulin NPH is something that will last often 8 to 15 hours. I kind of think of it as a 12-hour insulin peaking somewhere at around 6 hours. So again, some people will use this for prolonged G-tube feeds, like if you're using a G-tube feed that's lasting 10 to 12 hours, or if you're a person who's snacking throughout the day and eats a pretty hefty lunch, your doctor might try a once daily NPH dose. Long-acting insulins are Detamir and Glargine. They're also known as Lantus and Levemir. And these insulins, again, just bring your blood sugar down or keep it stable all day long. And they last approximately 24 hours. In reality, they probably last 21 or 22 hours. They have a very small peak. More recently, a ultra long-acting insulin has been released. It's called insulin degludec. It's by the brand name of Tresiba, and it lasts for about 40 hours. And so if you give that insulin once daily, as you're supposed to, say in the morning, it's eventually going to stack on itself a little bit. And so when you're using ultra long-acting insulin, you actually a lot of times need to decrease the dose by about 10 to 20% because of that insulin stacking effect. The nice thing about an ultra long-acting insulin, if you're on basal insulin, is that it does offer some variability in the time that you dose it. So it was actually invented for shift workers who might not have a very stable lifestyle. And so you can actually dose it anytime during the day as long as you're dosing it once daily. And if you have a very variable lifestyle or you are likely to forget your long-acting insulin, this might be a better option for you. It's not really been tested extensively in cystic fibrosis patients, but in all honesty, really none of them have been tested extensively just for cystic fibrosis. So insulin degludec is a newer one on the market. The one that I also wanted to touch on a little bit in more detail is insulin Fiasp, which again is fast insulin aspart. That's a short-acting analog, and it's meant for mealtime insulin. And the place where I really think that this probably has some value in cystic fibrosis is that it peaks just a little bit faster than Humalog or Novolog. And so instead of having to dose it 10 to 15 minutes before you eat, you can actually dose it right at the time that you eat. And I think that this just probably increases your quality of life a little bit because it matches as if you had pre-bolused when you are actually bolusing just at the time of eating, which just is one less step for you. I do think that if you have variations in gastric emptying, you might find a problem with Fiasp's faster action. Because if you're having a little bit more of a delay in your gastric emptying, then the Fiasp might peak a little bit too fast for you. You might find that you're having a little bit of postprandial low. So it's not right for all of my patients, but it is right for a lot of my patients, and does give people a little bit more flexibility. When I'm selecting a dose of insulin for my patients, I'm usually pretty conservative in my cystic fibrosis related diabetes population. And this is because most people actually have some insulin production on their own. And so I don't need to be as aggressive. Really what I'm trying to do in the early stages is replace that first phase insulin response. And then as it progresses, I'm systematically replacing more and more of the insulin production with shots rather than endogenous production from the belly. And so we start on relatively low doses. When I'm starting a long-acting insulin, I'm usually starting a weight-based dose somewhere around 0.1 to 0.3 units per kilo, and then I'm increasing that dose as needed according to blood sugars, hopefully to keep the fasting blood sugars somewhere between 70 and 100. When I'm starting on prandial insulins, which is mealtime insulins, that's my short-acting insulins, I'm usually starting for an adult at about a half to a unit, or half of a unit to a unit per 15 grams of carbs, and a half of a unit to a unit for every 50 points over 150. And then again, I adjust that based on blood sugars, trying to keep the blood sugar range during the day to be somewhere between 70 and 180, and even more ideally 70 to 140. Many people ask me if they can use other therapies besides insulin. Right now, the Cystic Fibrosis Foundation really only recommends insulin therapy for a couple of reasons. One is the disease, cystic fibrosis related diabetes, is really one of insulin deficiency. So the primary problem is that the insulin is just not being made efficiently. And so if it was insulin resistance, that's really what type 2 diabetics have, then you're available to use more medications to alter the way the insulin works so that it works better. But if your problem is that you're just not really making the insulin in the first place, then you really need to replace the insulin. In cystic fibrosis, there is definitely a component of cystic fibrosis, of insulin resistance, but it's really not the driving force. The real driving force is insulin deficiency. The other thing that is really important to think about is that insulin is the only medication that's really been shown to help with body mass index and pulmonary functions. And so when you ask yourself, what am I treating? Am I treating my blood sugar or am I treating my cystic fibrosis? I would argue that you're treating your cystic fibrosis. You're using your blood sugar as a tool to help you monitor and adjust your insulin, but you're not actually treating the hyperglycemia. You're treating the destruction that cystic fibrosis related diabetes causes on your lungs and the nutritional deficits that it causes as well. So if you're going to choose another agent, it might help you with your blood sugars, but if it doesn't help you ultimately with your disease, then maybe it's not helping you achieve your primary endpoints. We are studying alternate therapies to see if there are ones that are just as effective as insulin, but until somebody shows that another therapy is as effective as insulin with as minimal side effects, I would not routinely recommend that you use any therapy besides insulin. Specifically, people ask me about several medications. First, metformin. Metformin is a medication that treats insulin resistance. Again, this is not a primary problem for people with cystic fibrosis, and metformin can also lead to lactic acidosis, gastric upset, and weight loss, which are not ideal things for people who have cystic fibrosis. TZDs, like pioglitazone or one of those medications, they also treat insulin resistance. And they can have problems with bone mineralization and liver abnormalities, which might also be a concern for a patient with cystic fibrosis. Sulfonylureas increase insulin secretion from the pancreas, but there have been reports of hypoglycemia with that, just the same as there have been with insulin. And there's some concern that that extra stress of pressuring already injured beta cells to make more insulin might ultimately cause a burnout of the insulin making cells such that they no longer work, and then you're more dependent on insulin and you have less endogenous insulin production in the long run. There's also some concern that sulfonylureas might have some effect at the CFTR channel, and so if you're on modulator therapy, we don't know if those medications might interfere with modulator therapy. Meglitinides like repaglinide has a lot of talk about it. There's been a couple of studies on repaglinide. In Europe, they use repaglinide quite a lot. Dr. Moran, in her study, did not really show benefit in terms of pulmonary function or body mass index using repaglinide that was sustainable past 6 months. So they saw an initial benefit for about 6 months, and then the people on repaglinide went back to baseline, essentially, whereas the people on insulin continued to show improvement. There's been another study that was done on repaglinide that actually showed non-inferiority to insulin, but actually in that population, insulin did not show a benefit. And there's been so many studies that have shown a benefit of insulin. The question is, why didn't their study show a benefit? With the insulin, did they verify that the patients were actually taking their insulin in the insulin group? And so since neither medication showed a benefit, I don't know that you can call it an equal therapy. All I think you can say is that in that particular study, neither medication worked. There's some newer medications like SGLT2 inhibitors that make you pee out additional glucose. Those cause weight loss. And we don't really know that that mechanism is going to be of great benefit in cystic fibrosis, but it most certainly has not been studied in cystic fibrosis yet. More interestingly are the GLP-1 agonists, that's like Victoza and Ozempic. These medications slow gastric emptying and stimulate insulin secretion. These medications are used for weight loss as well, and so there's some concern that weight loss might not be of benefit, but now in our cystic fibrosis related population, there are some patients that are actually struggling with weight gain, and so there's some question about, well, could we use these medications to help weight loss in these patients as well as maybe blood sugar control? And that is a really interesting question. When you look at patients who have cystic fibrosis who do not take their enzymes, they actually don't release their own incretins very well. That's basically that drug. And those incretins that they're supposed to release then are supposed to stimulate their own insulin production. And so people with cystic fibrosis who are not taking their enzymes, that doesn't work very well. But when they take their enzymes, it restores that effect. So they don't actually have a deficiency of that chemical. They just don't produce it if they're not taking their enzymes. So the very first thing I think about in this patient population is, are you taking your enzymes? So again, go back to taking your enzymes. Then the second question is, if you're taking your enzymes, does a GLP-1 have added effect for you? It's possible. I think that's a definite question that we're looking at in study, and if you're available for a study in your area that is investigating that, that would be a perfectly safe place to enroll. I don't know that I would use it outside of study right now, but it's definitely something that we'll be thinking about, particularly in the age of modulators. There are some particular concerns with GLP-1s, like the possibility of pancreatitis and the possibility of inducing pancreatic cancers, and we don't know if people are born with an abnormal pancreas like people with cystic fibrosis are, if their risk of these problems would increase with those medications. Finally, I want to talk about just routine administration of insulin. I feel like, okay, now you're in this place, you've been told you need to take insulin, so now you have to actually take your insulin, and some people are taught how to take their insulin better than others. So some people are drawing insulin up with an insulin syringe and vial, and other people are administering with it what we call an insulin pen, where you dial your dose and inject into your skin. Other people are using insulin pumps. I'm going to talk a little bit about all of these, but primarily insulin pens, because that's what I think the majority of patients are probably on. So a couple of important things to know. One is you need to change the needle on your pen every single time. So this is not a situation where I would use the same needle over and over and over again. Most people will be prescribed a 4mm nano needle for their pen. Some people are prescribed these 8mm needles. That's really unnecessary. Most patients with cystic fibrosis don't have a great deal of subcutaneous fat, and if you're using a really long needle, it's probably going in too deep and hitting muscle. And so they've done really good studies on 4mm needles in people of all body sizes, and whether you have a lot of subcutaneous fat or just a little bit, 4mm is really adequate for most. If you're using an insulin syringe, the smallest needle is 6mm, and that's the one I would advocate for. When you have a pen, an insulin pen you're giving your insulin with, you need to prime it every time with 1 to 2 units. And what that means is you dial up to the 1 or the 2 and you push the button and you see if insulin is coming out so that the needle is completely filled. This does not just happen with the opening of the pen, although you usually need to prime more with the opening of a pen. So a lot of times you have to dial up to two or 3 times before insulin starts coming out. But actually with each subsequent shot, you also need to prime with 1 to 2 units. When you're injecting. If you're poking your finger with lancets, you should change that lancet every 8 to 10 pokes. So if you're checking your blood sugar multiple times a day, that's usually changing your lancet every 1 to 2 days. Insulin has to be disposed of after 30 days of opening it. And by opening it, I mean popping the top with a needle. Insulin will denature after about 30 days. By 38 days, it's essentially water. So if you're using insulin to save on money into that second month, you're probably not getting any insulin. You're probably just giving yourself a placebo injection, and that's probably why it's not working. So regardless of whether or not you have insulin remaining in your pen or in your vial, after 30 days, you have to throw it away. This is true with all insulins. And you probably want to store your insulin at either room temperature or have it be refrigerated, because if it gets hot, like if the sun hits it on the countertop, or if it gets very cold, like in the freezer, or if you leave it in your car and it gets hot or cold, it's going to denature and go bad. So the best place to keep it is the refrigerator because it's nice and safe, but you can keep it in your purse or on your person as long as it's not getting too hot or too cold, and that's why you can have it in a pump and it doesn't go bad. Speaking of pumps, that brings me to my last point. If you're filling up your pump, you should fill it with room temperature insulin whenever you can, because as insulin warms, it creates air bubbles. So you can create air bubbles in your line if you fill it with cold insulin. So if you have cold insulin, you might want to warm it in your hands before you fill your pump. So that summarizes the choice of insulin, the choice of dosing insulin, and how to administer insulin. These are great questions for your local diabetic educator or CAT. She can help answer your questions, and of course I'm always available to answer your questions.